Diabetes? No, not diabetes. No. What do you mean by coronary artery disease? Acute coronary syndrome. Acute coronary syndrome, right? Remember, you want to lower the heart rate for acute coronary syndrome, increasing the diastolic filling time, thereby increasing coronary artery perfusion. Okay? What else? Yeah, angina, stable angina. It's a good anti-anginal. What else? Aortic dissection, remember? Aortic disease, aortic aneurysms, anything related to the aorta. For HFrEF, what are the 3 beta blockers that are known to reduce mortality? Metoprolol succinate? Huh? Carvedilol, correct? Bisoprolol. Bisoprolol. What's the drug that causes drug-induced lupus? Huh? Nope. What's that? Hydralazine. Hydralazine. How do you confirm your diagnosis? Antihistone. Antihistone. Side effect of clonidine? If they miss a dose, they get rebound hypertension. Rebound hypertension. Why? Yeah, because it's a central alpha agonist. You have to remember these mechanisms of actions. It's an alpha 2 agonist in the presynaptic terminal. And by that mechanism, it blocks norepinephrine. So when you take a short-acting drug like clonidine, which is 3 times a day, norepinephrine drops, thereby dropping alpha stimulation, thereby dropping total peripheral resistance. The other arm of norepinephrine is beta. So it's the one drug that will give you hypotension and bradycardia. So when you miss a dose, you have a norepinephrine surge, which causes rebound hypertension. Rebound hypertension. What's the side effect of minoxidil? Wolfman syndrome. Unfortunately, your exam will not tell you Wolfman syndrome. Hypertrichosis. Hypertrichosis. Do no harm, right? Do no harm. If you do not understand the mechanism of action or side effect profile of the drug, you have no business prescribing it. Okay? Acute coronary syndrome. All right, this is really the foundation of cardiovascular disease. So, you need to understand the pathophysiology behind acute coronary syndrome. I need you to be able to distinguish between unstable angina, non-ST elevation MI, and ST elevation MI, and the accompanying medical management of each. You need to learn the ECG patterns of ischemia and infarction, and you need to be able to identify the culprit lesion. Is there a pointer here? Where'd it go? All right. So plaque is everywhere. We know from autopsy studies in the young, usually motor vehicle accidents or motorcycle accidents, that you begin to see at a very young age these atherosclerotic streaks in the lumen of the arteries. The reality is, with time, it progresses. And you can see here, not only in longitudinal, but in cross section, that you begin to develop progression of plaque. At some point, the plaque may begin to obstruct the coronary lumen. In this scenario right here, you can imagine when you exert yourself, heart rate goes up, blood pressure goes up, and as heart rate goes up, diastolic filling time goes down. And then you'll get exertional angina, chest pain, shortness of breath. You stop, heart rate goes down, and it resolves. That's stable angina. And we call it stable because we're really referring to the plaque. The plaque is stable. But sometimes the plaque changes in its anatomy. It becomes inflamed. And that inflammation, as you can surmise, is very bad. And with that, it can rupture. Now, this schematic shows a very significant plaque here rupturing. But the reality is, this plaque can rupture, or this plaque can rupture. It's really important for you guys to understand that, because when the plaque ruptures, that's what we're talking about when we're talking about acute coronary syndrome. Acute, it's an acute event occurring in the coronary vasculature. And the syndrome, what's the syndrome? Angina is a clinical manifestation, but what's the pathophysiologic cause of plaque rupture? Huh? So atherosclerosis is part of it, but what makes the atherosclerosis unstable? No, not hypertension. Endothelial cell dysfunction. You're on the right track. What makes the endothelial cell not functioning? Macrophages. You're on the right track. Inflammation. Inflammation. Acute coronary syndrome is an inflammatory event. Let me repeat that. Acute coronary syndrome is an inflammatory event. We don't understand how or why it happens. We've tried very hard to screen people to figure out who is at risk for plaque rupture, but we have not been able to find a good screening tool. The reality is, up to a third of individuals who come in with plaque rupture don't even have a risk factor. But the bottom line is, when the plaque ruptures, that's what we call acute coronary syndrome. The syndrome is a sequelae of events that occurs due to an inflammatory condition. Okay? When the plaque ruptures, a whole slew of events occur that causes the clinical manifestations. Now, you can actually take a catheter into the body and into the blood vessel and do an intracardiac ultrasound. Histologically, this is what you would find. Here's the coronary lumen, a lipid-rich core, fibrous plaque, and look at this lining right here. This is a very thin, fragile lining. On ultrasound, this is what it looks like, the lumen and the plaque. Here's the cap, and here's the lipid-rich core. Usually, when it becomes inflamed, this cap becomes unstable, and usually at the site of the rupture is what we call the neck. When that neck ruptures, contents inside the plaque now become exposed to the blood. And that causes a cascade of events that, as a clinical cardiologist, we try to counteract through medical therapy and intervention. Okay? This plaque has not ruptured yet. This plaque has ruptured. Here's the same lipid-rich core. Here's the thin cap. At the site of the rupture is what we call the neck. And the reality is, once the content of the plaque is exposed to the blood, you get activation of two different pathways. Number one, platelets, platelet activation. And number two, you get thrombus formation. Thrombus formation. If the plaque ruptures and you have complete occlusion of the lumen, how does this manifest on an ECG? Not ST depression, ST elevation. Every time you see ST elevation, this is what you're seeing. Okay? This is why we call ST elevation transmural infarction. All three layers of the myocardium are becoming infarcted. What is the difference between infarction and ischemia? Which one's necrosis? And what is ischemia? Yeah, not enough oxygen. They're on the struggle bus. They're not dying yet. They're on the struggle bus. ST elevation, necrosis. So, the difference between stable plaque and unstable plaque, look at this thick fibrous cap. Look at this thin fibrous cap. This will cause you what entity? What clinical entity? How does that plaque present as? Huh? Stable angina. Stable angina. Exertional chest pain. The one on the right, if it ruptures, is what we're referring to as acute coronary syndrome. So take a look. Plaque growing, 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 obstructing the lumen, becomes inflamed, ruptures, site of the plaque rupture, thrombus formation. Let's take a look at it again. Progression of plaque. This is over decades. Plaque, then thin fibrous cap begins to form. Site of plaque rupture, contents released, platelet and thrombus formation. This leads to transmural infarction. It's a very dynamic process. But the key here is for you guys to understand that this is an inflammatory event. Yes, activation of macrophages. Yes, you're going to get evolution of the plaque. You're going to start getting destabilization of the thin cap, and ultimately plaque rupture. So everything we're talking about from a pathophysiologic perspective, this is what we're talking about. Stable angina is a different entity. Stable angina means that you have a stable plaque, yet it's obstructing blood flow. It causes predictable exertional chest pain. So my patient says, every time I take out the garbage, I get chest pain. 5 out of 10. I drop the garbage at the end of my driveway. I stop for 30 seconds. Goes away. Next garbage day, I take out the garbage. End of the driveway, same 5 out of 10 chest pain. I stop, 30 seconds later, it goes away. Predictable exertional pain. They have a stable plaque that's obstructing blood flow when the heart rate goes up and blood pressure goes up. Unstable angina is a different beast. Unstable angina is plaque rupture. So these are the patients that come in with unprovoked chest pain. Left-sided, radiating up the jaw, down the left arm, the classic symptoms. That's definition number 1. Chest pain at rest. Definition number 2. Definition number 3. Someone with stable angina, but the pain has somehow changed in intensity, frequency, or duration. So that same patient says, you know what? Now that when I take out the garbage, I get chest pain and I'm not even at the end of the driveway. Or before, it would be at the end of the driveway, and now instead of 5 out of 10, it's 8 out of 10. Do we have a pointer? Or they say, when I stop at the end of the driveway, instead of it stopping after 30 seconds, it stays for minutes. Change in intensity, frequency, or duration. Okay? Any questions on our definitions? So once you have plaque rupture, ultimately it leads to multiple different entities. Turbulent blood flow, exposure of subendothelial collagen, the contents that were in the plaque, cytokines and tissue factors, intraplaque hemorrhage, ultimately leading to vasospasm, decreased in vessel lumen, platelet activation, and coronary thrombosis. What's interesting to note is that normal endothelial cells actually release vasodilators and antithrombotic cytokines. Normal endothelium have protective mechanisms. Once you start developing plaque over the endothelium, you no longer have those. So you're beginning to see that it takes a cascade of events to ultimately lead to coronary thrombosis. Everything we do in the management of acute coronary syndrome is counteracting coronary thrombosis, and that is avoiding clots and deactivating platelets. Those two are fundamental in stopping this cascade. So let's start with an example. 29-year-old guy comes in with a history of polysubstance abuse, heroin, and cocaine, last used 1 month ago. He's obese and has a 50-pack year history of smoking. He's currently smoking 1 pack per day, and he presents with 2 to 3 day history of intermittent sharp chest pain, lasting 2 to 3 seconds without any diaphoresis, nausea, vomiting, or radiation. It became worse with exertion and alleviated at rest. He has never had this pain before. On the day of presentation, the pain was substernal, 10 out of 10, sharp stabbing, left-sided chest pain, down the left arm and through to the back. He was sleeping and the pain woke him up. The episode was associated with diaphoresis and nausea with 1 episode of vomiting. He has no premature coronary disease or sudden cardiac death in his family. What's your diagnosis here? Unstable angina? Anything else? Huh? No, this is all the information you have. At this point, what do you have? Unstable angina. Why? Well, he didn't even have stable angina. Why are you calling it stable angina? But that's still unprovoked chest pain, right? Stable angina is predictable chest pain. Stable angina is predictable chest pain. Is there anything predictable about this? Yeah, if anything, the guy is having unprovoked chest pain, which is escalating in a crescendo manner. So, what's your diagnosis up to this point? Unstable angina. Unstable angina. So, this is key point number 1. Thank you. Which one's the pointer? Oh, it won't work because of the light. Yeah. Okay. Um, yeah. So key point number 1: unstable angina is a clinical diagnosis. Just talk to the patient. Unprovoked chest pain at rest, unstable angina. Stable angina has to be predictable. No change in intensity, frequency, or duration. This guy is having clear escalation of his symptoms. Why isn't it a STEMI or non-ST elevation MI? Yeah, we haven't gotten any diagnostic test yet, right? So it can't be C or D. So on exam, He's tachycardic, hypertensive, setting 97% on room air. He's alert and oriented, diaphoretic in mild distress. Neck is supple, non-tender, lungs are clear to auscultation. Cardiovascular, regular rate and rhythm, no murmurs, abdomen soft, non-tender, musculoskeletal, unremarkable. He's not a diabetic. He's got a normal A1C. His cholesterol panel with an LDL of 137. Urine toxicology is negative for cocaine. EKG. Have you guys had EKGs yet? Good. So you're going to be experts here. So for for the time being, I'm just going to tell you guys that an EKG is just as good as a comparison in the past. We always like to compare current ECGs from prior. We had one prior, and here you can see P waves before QRS. This is normal sinus rhythm. And when someone's coming in with chest pain, you're really looking for ST elevations or ST depressions. ST elevations, as we talked about, is a transmural infarction. ST depression is subendothelial ischemia. Ischemia means struggling for oxygen and blood. Infarction is you're not getting any blood. You have active necrosis of the tissue. So here is his baseline. I don't see any ST elevation. I don't see any ST depression. It's a remarkably normal ECG. What do you see here? What's the rhythm here? What's the rhythm? Huh? Anyone? Sinus rhythm. Regular means nothing. Sinus rhythm. How do you know it's sinus? Yeah. Look at this. P wave. Look at this P wave. Upright P wave in 1 and 2 means that it's sinus rhythm. Let me remind you, a P wave only denotes atrial depolarization. A P wave only denotes atrial depolarization. If the morphology of the P wave is upright in 1 and 2, it is sinus rhythm. Here's his chest x-ray. Have you guys done chest x-rays yet or no? A little bit. All right. So this is a portable chest x-ray. It's important to note because it affects your interpretation. Here you can see the airway right here. The trachea is midline, bifurcation of the airway right here. Um, you can see, as with most portable x-rays, you can see how it's lopsided. The right clavicle is upright and the left clavicle is horizontal. And this is because the patient's just lying in bed like this, and someone goes in and does a quick portable chest x-ray. So this again compromises the integrity of the chest x-ray. So he's rotated a little bit. But if you look at his airway, he has good airway. You're typically supposed to have about 8 to 10 ribs. 1, 2, 3, 4, 5, 6, 7, maybe just 8 again because it's portable. They're laying down. They're not fully expanding the thoracic cavity. Cardiac silhouette is intact. You can't really comment on the cardiac size because it's a portable x-ray, another limitation of portable. But overall, you see very good lung fields with no congestion and crisp costrovertebral angles, denoting no pleural effusion. And then the right hemidiaphragm is higher than the left, obviously because of the liver. So this is a normal x-ray. Cardiac silhouettes. the borders of the hearts. So you order a troponin, and the troponin is elevated, 0.18. Normal troponin is less than 0.01. What is your diagnosis? Huh? STEMI. Why? Yeah, where do you see ST elevations? Yeah, so you really don't see ST elevations here. So yeah, you may think V2, but then you look to V3 and you're like, wait a minute. Yeah, never mind. You need ischemic changes in two contiguous leads. Two contiguous leads to give you a pattern. An isolated finding is not a pattern. So ECG does not show ST elevations. However, when you measure blood for troponins, these troponins is very sensitive to myocardial death. Therefore, your diagnosis is non-ST elevation MI. Let me remind you, the reason why we call it non-ST elevation MI is because I gave you an ECG and there is no ST elevation. Yet you can measure cell death through laboratory. Does this make sense? If you just sit on this, if you just wait there and just sit in an hour or two, that thrombus will get larger and larger and larger, and it would evolve into an ST elevation MI. So early diagnosis and treatment is critical. Troponins. One of the limitations of troponins is it takes hours for it to become measurable in the blood. Let me say that again. It takes hours, up to 3 hours. So if someone comes in with chest pain and plaque rupture, for the first 3 hours, EKG and troponin will be normal. So you really have to have an index of suspicion, and every hour or two, we get another ECG and another troponin because we understand the limitation of the test. As you can see here, you won't even begin to have measurable troponins until 3 or 4 hours. What is the next diagnostic test? Catheterization. All plaque rupture leads to cardiac catheterization. All plaque rupture leads to cardiac catheterization. What do I mean by cardiac catheterization? What is that? Someone in the back. Yeah. Yeah. Yeah, exactly. You don't go through the left atrium. You don't go through the left ventricle. You actually go up. Yeah, you go up the descending aorta, down the ascending aorta, and the coronary sinus is located where? In the aortic valve. And you're able to shoot dye in the coronary vasculature and take pictures of the heart, you're looking for the plaque that has ruptured. You're looking for the site of the plaque rupture. You want to extract as much thrombus as possible before you open up the site of the rupture with a stent. There is no medication anyone can give a patient to do this thing. You have to go in there, manually restore blood flow. And you're absolutely right. When I was in your shoes, we were going femoral approach, femoral artery. But can you imagine puncturing the femoral artery with a catheter? Technology has gotten so good that the catheter sizes have gotten smaller and smaller and smaller, and now they're tiny. Now you can go through the radial artery, up the arm, and right into the aortic valve. That's what I'm talking about when I'm saying cardiac catheterization. The rest of the management is all trying to block this progression of this plaque rupture, platelet activation and thrombus formation. Aspirin, shocker. You load them with aspirin, platelet inhibition. Platelet inhibition is so important in plaque rupture that we do it twice through two different mechanisms, two different receptors. Aspirin, as you know, is a COX inhibitor. Plavix or clopidogrel or prasugrel, another oral platelet inhibitor. IV heparin. You heparinize these patients. Full systemic anticoagulation. Why? Because the plaque rupture is a thrombus forming event. What's causing the transmural infarction is thrombus. So you need heparin. Beta blocker. This should come as no surprise. The one time we use beta blockers, why? Reduce heart rate, increase diastolic filling time, and increase coronary artery perfusion. It's a negative inotrope, and therefore the heart will also work less, which is a good thing. Oxygen, we actually, unless they're in pulmonary edema, we don't give oxygen. Nitrates, nitrates are venodilators, right? So they reduce preload of the heart, but they also have an added benefit where they dilate the coronary vessels. There's very few drugs that dilate the coronary vessels. When you're having plaque rupture, is dilating the coronary arteries a good thing or a bad thing? It's a great thing. You're increasing the blood supply to a struggling heart. And a high dose statin. Why statin here? Yeah, so you're not wrong. Patients with plaque rupture will always require statin therapy. But what is key about initiating statin at this point? If I start a statin here from his cholesterol, I'm going to reduce his cardiovascular risk over the next decade. But not now. Why am I doing it now? Anti-inflammatory. Correct. The pleiotropic effects of statins. Anti-inflammatory. Is plaque rupture an inflammatory event? Why, yes, it is. Therefore, high dose statin for anti-inflammatory effects. Take a look at his ECG. We took him to the cath lab. We revascularized him. This is his ECG after revascularization. What has changed? Huh? Yeah, so now you see ST elevations in V2 and V3. What else do you see? Sinus rhythm, yes. Huh? Yes. Right axis deviation, yes. What else? I'm looking for a very, look at the ST elevations and tell me what you see. What's that? I heard Q wave inversion. You have both. You're saying two very good things incorrectly. Pick one. Just pick one of those two things. What is it? No, say it. Inverted. Pick the other one. Pick the other one. Inverted. The inversion you're talking about is right here. This is a T wave. So you're absolutely correct. He has anterolateral T wave inversions. Very abnormal, right? ST elevation with a biphasic T wave, right? Very abnormal, and you did not see this on his ECG. Now go back to your other statement. What was your other statement? Q waves. Q waves. Look how abnormal this is. There is no upward deflection here. You have lost your R wave. It is Q waves. Let me remind the audience, what does ECG look like? Tiny r, big R, big R. Q, Q. I can't really tell here what this is. I don't know if this is a Q or an R, but look at this. There is no R in the anteroseptal leads. What does this denote? What's a Q wave? Huh? Is in this scenario, a Q wave means what from an anatomy perspective? Well, yes, it's ventricle depolarization. It's infarction. He's infarcted. The tissue's dead. ST elevation is active infarct. Q wave, completed infarct. So if this guy came to my office and I saw this ECG, the first thing I would do is ask him, have you had a heart attack in the past? Q waves means you've had a heart attack in the past because it equals a prior infarction. ST elevation, active infarction. Q waves, prior infarction. Huh? Oh, yeah, absolutely, necrosis. Yeah. For my seniors, what vessel did he infarct? LAD, prox or mid? Pick the other one. Remember, the involvement of V1 in V2 denotes prox LAD. If you are going to infarct, please leave your LAD alone. The LAD is called the widowmaker. It provides blood to the antero, lateral, septal, apical part of the heart, which involves your left ventricle. Left ventricle. Okay? LAD. Is his ejection fraction, his normal LV left ventricular ejection fraction, normal or abnormal? Abnormal, yeah. He's had, I would quote this as a prior anteroseptal infarct. The LAD provides blood to your entire left ventricle. So if you infarct the LAD, you will have heart failure with reduced ejection fraction. The number one cause of heart failure with reduced ejection fraction is a prior infarction. We'll get to this on Thursday. But my expectation is not only will you be able to identify the active ST elevation MI, but you also have to be able to identify the prior myocardial infarction. Look right here, side by side. Look at the R waves, look at the Q waves. Back to the point, you need ST elevation or Q waves in two contiguous leads. Here you have a Q wave in V1, V2, and V3. That is a clear pattern. For the first years, I know you guys use your UWorld or whatever USMLE. This is what we're talking about. This is a QRS complex. The downward deflection is a Q. The RS has only an upward deflection. Monophasic R, this is only a downward deflection. This is a QS, and this is an RSR prime. This is what we're talking about. Downward deflection, Q wave. Look at these Q waves. There is no upward deflection here. Okay? Normal is an RS pattern. A QS pattern is very abnormal. This is from your first aid book. You need to know the anatomy of the ECG. You need to know it. All right? My preference would be that you don't memorize, that you understand it. But the LAD is in the anteroseptal part of the heart. So V1, V2, V3, V4, that's all LAD. RCA supplies the inferior portion of the heart. 2, 3, and AVF are the leads. And left circumflex is 1 in AVL with V5 and V6. If you see ST elevations or Q waves in those leads, that is the vessel that has been infarcted. And just like the ECG predicted, patient was taken to the cath lab, and lo and behold, LAD. LAD. It's a fun game that we cardiologists like to play. When STEMIs come in, where's the lesion? Where's the lesion? Look at the ECG. What's the EF? And then we check it based on gold standard. But I like to talk about this with you guys because number one, you will never actually be able, you will never be expected to identify or interpret echoes or coronary angiograms, ever. But I think it's useful to talk about it because at the end of the day, the pathophysiology, if you can link it to what's happening clinically, you will begin to understand the concepts that we're trying to teach you in the preclinical stages. Any questions on case one? All right, another case. 40-year-old is coming in. Active smoker, 15-pack year history of smoking, 1 pack per day. He's got hypertension. He actually suffered a subdural hematoma, and he's status post a skull fracture from a motor vehicle accident. He's got anxiety, and he presents with left-sided chest pain that started on the 21st. He describes the pain as a squeezing in nature, mid-sternal chest without radiation. It occurred while he was sleeping, and it woke him up from sleep. It improved with Xanax temporarily, but it never completely resolved. His symptoms became worse, and the following day, he started to develop diaphoresis and fatigue. When the pain did not resolve, what actually concerned him was that he developed shortness of breath. Dyspnea with exertion. He presents on the 23rd. On exam, he's hypotensive, he's alert and oriented, diaphoretic, in moderate distress, lungs supple, non-tender, lungs are clear, respirations symmetrical, normal rate, regular rhythm, no rubs, murmurs, or gallops, abdominal and musculoskeletal exam unremarkable. He's not a diabetic. His cholesterol panel actually doesn't even look that bad. Chest x-ray. Just for the sake of time, ER, they always do portable. Portable chest x-ray. A little bit rotated on the right side. The right clavicle is higher than the left. Airway is midline, bifurcation. Central looks good. Cardiac silhouette looks good. The right and the left don't look enlarged. Right hemidiaphragm higher than the left due to the liver. Crisp costrovertebral angle. No pleural signs of pleural effusion, and no significant pulmonary vascular congestion. Overall, unremarkable. ECG. Look at his ECG. What do you see? Huh? Lead V2. Lead lead 2 has a what? Okay, so remember what I told you. I want contiguous leads. Anytime you're interpreting an ECG, especially for chest pain, look at the coronary anatomy. You're trying to locate where the plaque rupture is, right? So if you want to look at lead 2, you're talking about inferior leads. So you want a pattern in the inferior leads. You want a pattern in the lateral leads. What's AVR? Which, where on the body is AVR? Right, yeah, it's the right shoulder, right? So the lead goes this way. So lead AVR is the reciprocal image of everything else. Does that make sense? All the leads are going to the left and inferior. AVR is going over the right shoulder. So AVR is actually a mirror image of what you would normally expect. So you would expect an upright P wave to be downward, an upright QRS to be downward, an upright T wave to be downward. What else? Fantastic. Fantastic. You have clear ST elevation starting from V2. Look at this. Look at this ugly 3 mm ST elevation. Then you look at the next lead, V3. It's worse. This is actually what we call or nickname tombstone. You've got this concave upward elevation, right? It's a tombstone. You already have two contiguous leads. So V2, V3, well, there it is, V4. And even in V5, it's starting to come down in V5, but you have 1, 2, 3, 4 leads with ST elevation. And more importantly, what else did you say? What else did you say? Q waves. Q waves. There's no R wave anymore. Why is he Q'd out? Huh? Yeah. When did he start having symptoms? 2 days ago. He had symptoms 2 days ago, ignored the symptoms, but started developing shortness of breath. He came in with shortness of breath, and he has completely infarcted what territory? Left anterior descending artery. Correct. So, your diagnosis here is STEMI, ST elevation MI. So, based on his ECG, he got to the hospital just in the nick of time. His heart did not suffer any damage. Take him to the cath lab. B, he missed the boat as he got to the hospital too late. The damage has been done. Just treat him with medicines, aspirin, statin, and beta blocker. C, he is presenting late, but he still needs intervention. Take him to the cath lab. Or D, he got to the hospital just in time. His heart did not suffer any damage. He needs a stress test to assess for ischemia. C. Why C? You're going C. You have faith. Let me simplify for you. Is he having symptoms? Does he have ST elevations? To the cath lab, right? He's still having symptoms, and he still has ECG evidence of transmural infarction. Now, he may not recover all of the function after revascularization. That's clear. But you still need to take him for intervention. Good. Persistent ST elevations. Where's the plaque rupture? Left anterior descending artery. Why? Yeah, because V1, V2, V3, and V4 is anteroseptal. Look at this right here. LAD. LAD feeds the anterolateral and apical wall. Look at this. This entire section is the left ventricle right here. The left ventricle is being supplied by the LAD, right? So, right here, V1, V2, V3, that's the entire anteroseptal. V3, V4, V5 is now the lateral and apical. RCA feeds the inferior. 2, 3 in AVF are your inferior leads, and 1 in AVL with V5 and V6 are your lateral leads. So when you are interpreting ECGs and you're trying to locate where the lesion is, you go in the distribution of a coronary vessel. Yeah. Yeah, so I don't know what to do with this. The reason why I don't know what to do with this is because I don't have a prior ECG to compare it to. That may be his normal ECG pattern, right? But do you see any ST elevation or ST depression in 2-3 in AVF? No. So it's clinically irrelevant in this case. Okay, good. So what do normal coronaries look like? This is a catheter shooting the RCA. Look at this, normal right coronary artery right here. Catheter, this is the aortic sinus right here. The aortic valve is right over here. You take a catheter right into the coronary sinus, and you see beautiful blood supply in the RCA territory. This is the right coronary artery. This is the left-sided system, much more complicated. This is the left main. The left main is what we call the mothership. It supplies everything to the left side. Very large artery comes down. This is the left circumflex, obtuse marginal branch of the left circumflex. This is the lateral wall. This is the apex. And this is the anterolateral wall. So LAD right here. This entire vessel is the LAD. LAD, take a look at this. Massive LAD. The LAD always feeds the apex. You guys remember from anatomy what the definition of the LAD is anatomically? Did you guys study this or no? Maybe. Number 1, it's the vessel that lies in the interventricular groove. Interventricular groove. Number 2, it supplies septal perforators. And number 3, it feeds the apex. It's the vessel that feeds the apex. And here is the apex. Here are the septal perforators and the large LAD. Our patient was taken to the cath lab. Left main, circumflex. What is this? What is this? There's a complete absence of blood flow here. You can see the hang up of dye right here is actually in the vessel. Where's the blood flow here? This is the circumflex feeding the lateral wall. Where's the LAD? That's MIA. You take a catheter into the LAD. You take a catheter in the LAD. You open it up with a stent. This is a stent. And there is the LAD. You've restored the blood flow into the LAD. When I'm talking about the anatomy of the LAD, look, here's a patient's chest. V1, V2, V3, V4, V5, V6. We call these leads the precordium leads because they're on the precordium. V1 and V2 are anterior. V3 and V4 are anterolateral. So if you look at the anatomy, V1 and V2 are right at the beginning of the LAD. V1, V2, V3, V4. So V1, V2, V3, and V4 follow the LAD anatomically. This is why I'm telling you, when you see ST elevations in V1 and V2, you have involvement of the prox LAD. V3 and V4 is more distal. So you're sparing the prox LAD, but you're affecting your mid to distal. This is why it's so important that when you interpret ECGs, you follow the coronary anatomy. I told you guys that when we end up doing these procedures, before we deploy the stent, we do what's called a thrombectomy. Because there's so much thrombus in the blood vessel, we try to extract as much of the clot out before we perform the revascularization. In this case, look at the clot. That's in the LAD. You think there's any blood flow coming through that vessel? When you see ST elevations on ECG, I want you to think of this. Transmural infarction. Everything that we do with an ST elevation MI is trying to prevent the propagation of clots. The more clot burden is in the coronary, the greater the infarction. If the plaque rupture happens in the prox versus the mid, which one do you think suffers more damage? Prox. Because everything after that prox is now becoming infarcted. Mid LAD, you're sparing the prox, so the real estate that's affected is less. Heparin. This is why we heparinize these individuals. Aspirin. This is why we load aspirin on these individuals. And it should come as no surprise that the gentleman arrived 2 days late. And even though we took him for cath, look at his ECG. Is it normal? Well, for one, he still has ST elevations. You're not wrong. In V2, he still has ST elevations. But what else do you see? Look at the Q waves. Q wave in V1, V2, V3, V4, V5, even V6. This is a massive anterolateral infarction. He's completed the infarct. So when I see these patients in the hospital or in my office, I take a look at their ECG, and the first question I ask is, "You've had a heart attack, haven't you?" Very, very specific. When you see these patterns in the distribution of the coronary vessel, take your money to the bank. Do you think his heart function is normal? Absolutely not. I promise you, he has heart failure with reduced ejection fraction. This is what we call ischemic cardiomyopathy. This is also why education of the public is so critical in what we do in healthcare. If you do not educate your patient population about the signs of a heart attack or a stroke, you as a clinician are limited by time of diagnosis to the time that they recognize something is wrong. If he recognized on the 21st that he was having a heart attack, he would have gotten to the hospital sooner, he would have been revascularized sooner, and you would have saved myocardium. We like to say in cardiology, time is myocardium. Time to revascularization is so critical in saving the myocardium that in order for you to run a cath lab, you need to have 24-hour access to the cath lab. Because if they roll into the emergency room with an ST elevation, you have to have a catheter in their heart within 90 minutes. Or else you will not be granted privileges to have a cath center. Okay? Time is myocardium. His ejection fraction will certainly be low. So, movies. I love movies. Who's seen Titanic? Excellent. Very good. What's the difference between ischemia and infarction? It's not a trick question. Yeah. So which one? Yeah. Fantastic. Fantastic. Yeah. In the left, Jack is struggling. Jack is struggling. He needs help. He's not dead. He needs help. When you see ST depressions, positive troponins, T wave inversions, think of Jack. Please, Rose, move over. Give me some room on that large board of debris that can easily fit 2 or 3 people. On the right side, it's over. He's infarcted. Q waves. This is Q waves. This is ST depression. I love this analogy, partly because there's so many memes about it, right? About how much room was on there, and the director and Kate Winslet. Everyone's been asked about this very controversial issue, how you can fit so many things on that plank, but no one would move for Jack. All right. Take home points. Acute coronary syndrome is an inflammatory event. If I have not convinced you of this, I have not done my job. You know, in the hospital, when we see ST elevations, after we revascularize them, patients tell me, but doc, I just had a physical with a cardiologist. I just had a stress test 6 months ago. Everything was fine. I was given a clean bill of health. Why did I have a heart attack? How would you explain that to them? What does that mean? Why was the stress test normal? Huh? I'm sorry, I can't hear you. Yeah, but the stress test was 6 months ago. We get this all the time. Patients walk into my office. I just want to make sure everything's okay. I heard on the news so and so had a heart attack. My best friend just had a heart attack. I want to make sure that it doesn't happen to me. Yeah, you're on the right track. Yeah, the stenosis wasn't enough to cause symptoms. Stenosis progresses over decades, right? Over decades. But you're on the right track. I'll tell you, when he had the stress test, this is where he was. He had plaque, but the plaque was stable. Most stable plaque causes no clinical events. Even if you put this guy on a treadmill, an exercise tip, passed with flying colors. In the past 6 months, something happened that caused that plaque to become inflamed. And that stable plaque became unstable. And that's what makes plaque rupture so dangerous. And that also is what makes my job so difficult. You can come into my office and say, I want to make sure everything's okay. I can't tell you it's going to be okay. You want a stress test? Fine. It means nothing to me, and it should mean nothing to you. You focus on lifestyle changes, blood pressure control, diet, exercise, weight loss, right? Control modifiable risk factors. Exercise. For the love of all things, exercise. You guys are young. You should be exercising. What? All the time. All the time. I say no. There's no role for coronary angiography as a diagnostic screening test. It's invasive. It's certainly not without risk. But you can do, we have some things we can do. But at the end of the day, if you're telling me, am I going to have a heart attack or not? I'm going to say, I have no idea. 1/3 of individuals who come in with plaque rupture have no risk factors. Just let that sink in. 1/3. No diabetes, no obesity, no hypertension, no family history. Blood pressure's good, cholesterol's good, and they come in with plaque rupture. Stress test, no stress test. Whoever can develop a screening tool that can predict inflammation and plaque rupture will not only win the Nobel Prize in medicine, but they will become a billionaire. It has to be cheap, non-invasive, and accurate. That's what you want in a screening test. We're not there yet. So ACS is an inflammatory event. Acute coronary syndrome is an umbrella term. It captures unstable angina, non-ST elevation MI, and ST elevation MI. Okay? Acute coronary syndrome is an umbrella term. Unstable angina, just talk to the patient. You don't need any diagnostic tests. Just talk to the patient, take a history. Unstable angina. if anyone comes in with chest pain, your first diagnostic test should be a what? ECG. Why? Yeah. ST elevation, MI, is a medical emergency. You have to diagnose ST elevation, MI quickly. The first diagnostic test will always be an ECG. Does the troponin matter if you have an ST elevation on your ECG? No. In fact, if a patient develops chest pain 30 minutes ago and they walk into the ER, is the troponin even going to be positive? No. So if a lot of times the 12-lead ECG will show ST elevations and the troponin's negative. It doesn't change your management. Proceed to the cath lab. It's really important to recognize the coronary distribution on an ECG. This comes with practice. You just need practice. Be very systematic in the way you interpret ECGs. For ST elevations or Q waves, you want to follow a coronary distribution. V1, V2, V3, V4, 1 in AVL, V5, V6 for circumflex, 2, 3 in AVF for RCA. You have to understand the coronary anatomy. I hope I've convinced you that the pathophysiology of plaque rupture is simple. Plaque rupture is inflammatory, causing coronary thrombosis via platelet activation and thrombus formation. That's it. Everything that we do, aspirin, clopidogrel, heparin, it's all trying to block this activation cascade of thrombus formation. If you understand the pathophysiology, the clinical management will become rudimentary. If you don't understand pathophysiology, you will rely on mnemonics. The med students that I work with, they have a mnemonic for everything. Understand what's going on now to make your clinical acuity much better when you're on the wards. And then acute coronary syndrome, unfortunately, many people don't recognize their symptoms. Men and women don't recognize the symptoms, and they come in too late, and they've infarcted. Acute coronary syndrome is one of the leading causes of HFrEF globally. And you'll see tomorrow we'll talk about when they don't recognize symptoms quickly, what are some of the complications that they come in with? And then the long-term sequelae and complications of heart failure, which is a multi-billion-dollar drain on the American healthcare system. It is staggering, the costs to manage long-term heart failure patients. Any questions? Yes. No. No, actually, there aren't. We use statins in the hospital to stabilize the plaque. Okay, they cause plaque stabilization through their anti-inflammatory effects. Rosuvastatin or atorvastatin are the high intensity strength statins that we use. There's a lot of newer agents that are coming out that also have anti-inflammatory properties. However, in primary prevention, before the event, there's very little we have to offer. Uh, Sometimes people come in with plaque rupture. When you're talking about cholesterol, there's a panel that you get, right? Total cholesterol, triglycerides, LDL, and HDL. Which one's the one that is closely tied to atherosclerosis? LDL. LDL. The higher the LDL, the greater the cardiovascular risk. Very robust longitudinal data that we have in the United States and globally. Sometimes patients come in with plaque rupture, prox LAD, their LDL is normal. In a lot of ways, that's worse than if their LDL was high. Like, this is someone that would have come in my practice and I would have said, cholesterol panel looks fantastic. In some patients, there's this nidus of inflammation that we don't truly understand. And I tell them, despite your LDL being 70, I got to get it down to 20 because you had plaque rupture with an LDL of 70. It's a lot easier for me to have a conversation with someone with an LDL of 200. All right, diet, exercise, weight loss, you have something to provide them. But and this is why not only is that scenario with a normal LDL shocking to us as clinicians when they come in with plaque rupture, we don't understand what the inflammatory condition is in them. They have something that caused them to have plaque rupture. And if you have plaque rupture once, you're going to have it again. So we're super aggressive in LDL control, weight control, blood pressure control. Whatever modifiable risk factor there is, we try to control. The counter side of that is there are patients with conditions that have chronic systemic inflammation. You guys know what these are: obesity, CKD, diabetes, lupus, arthritis, these low indwelling chronic inflammatory conditions, right? Diabetes destroys everything, all the blood vessels. But we can control that. I can put you on medication, insulin, drop the weight. Now in the US, there's this huge craze for these weight loss injectors, Wegovy, Ozempic, that no one cared about when it was just for diabetes, but now patients are paying out of pocket just to drop weight. Yeah. LDL is my main focus. With that being said, if your HDL is high, that's a very good sign, right? I have patients HDL 90 to 100. That's a great sign. But HDL also tends to drop with age. And the other thing is that we've tried so hard with medications to increase, HDL, right? Omega fish oil, right? Who's heard of omega fish oil? Yeah, everyone. We live in a society of, doc, give me a pill, give me a pill, give me a pill. We tried omega fish oil for a long time. The only thing it did was it made our patients gassy, and when they would fart, it would be this disgusting fish odor that was uncomfortable. And many of them, they would get like these flushing sensations because it's somewhat of a vasodilator. You know what the only proven way to increase your HDL is? Exercise. Exercise. When I was in your shoes, we thought it was cardiovascular exercise. And let me be clear. If you're a marathon runner, if you bike, if you do cardiovascular exercise for 4 or 5 hours a week intensely, your HDL is going to be higher than the population norm. I promise you. But if you take a look at your lipid profile before you start medical school and after you finish your training, you will get chills down your spine. You, you know, professional degrees are very inactive. Medicine, they've done studies, doctors don't live as long as our peers. Stress is incredibly toxic for the body. Stress reduction. Try reducing my stress, you know? As a cardiologist, everyone is running away from STEMIs. I'm running towards a STEMI. Stress is my life. We don't live as long, right? I gained 20 pounds in medical school, right? So, and then the older you get, the more entrenched you get in your practice, the harder time it is to carve out time for yourself. So the best advice I can give you guys is relax. Relax. You're in the Caribbean. Every day is a beautiful day. And exams are going to be a part of your life. MCAT, step 1, step 2, step 3, boards, recertification, right? Exercise. One of the things I always tell my patients, and I'll tell you guys, is if you carve out healthy lifestyle habits when you're young, you will carry them with you as you age. It's very hard for me to have these conversations with my 250 or 300-pound patients and tell them to exercise when they haven't exercised one day in their life. My conversations are, can I have you walk 30 minutes a day? My patients want a handicap certificate after they have a STEMI. I say, I write on a prescription, park the farthest parking spot available and then walk into the office. Because that's as much exercise that they're going to get. Right? Lifestyle is hard. Medicine is hard. Life is hard. If you want to be good at what you do, no matter what it is, it's going to be hard. Accept the fact medicine is a calling. It's not an occupation. Medicine is a calling. You guys answered the call. It's hard work. You guys know it's hard work. But work hard, study hard, but carve out an hour, 90 minutes for yourself. In the United States, we have this ugly term, well-being. It has nothing to do with well-being. It's balance. Have balance in your life, no matter what your profession is. I don't even know if I answered your question. Any other questions? All right, guys, thank you.